Okay, good morning, good afternoon, depending on where you're joining us. Welcome and thank you for joining us for today's webinar. Our topic for today is screening for prostate disease and cancer. Today's webinar is hosted by a few of us here. We have Dr. Shannon Ashley, a Preventative Medicine Physician, on the call today. Thank you, Dr. Ashley, for joining us. We also have Dr. Jamil Muasher, one of our radiologists and a prostate imaging specialist. So thank you to Dr. Muasher as well. And myself, I'm Eric Chafe. I'm the Vice President of Sales. So before we hop over to the kind of details on the topic, let me give you all just a high-level overview of who we are. I understand some of you might be physicians who are working with us already. Some of you might be here to learn a little bit more. But at the highest level, we are a dedicated whole body imaging practice. Today, we have 17 clinics across the US and Canada, and over the next 12 months, we'll probably be close to doubling that geographic expansion. You'll see us open in the UK in Q1 and Australia, and of course, opening in more markets within the US. Our focus is primarily and singularly whole body imaging. And really, we're the world's first imaging practice focused on this solely. And today, our focus remains on routine longitudinal whole body imaging. At this point, this makes us the largest, certainly in the US, doing this with an estimated 10 to 15 times more scans completed compared to any other company doing this or comparable academic center of excellence. So this is our expertise, right? We have 80 plus radiologists trained on whole body imaging. And we're proud to say that our team has played a major role in the technical advancement of MRI application for general whole body imaging. And we certainly expect to remain on the forefront of this movement. So a little bit on the growth and impact. As I mentioned, this is our expertise. We have over 15 years of conducting whole body imaging with MRI. And I know many of you might have only heard of us over the last couple of years. Well, that's because in the beginning, we started honestly quite small. We had a single clinic with one magnet up in Vancouver, where I'm located, and we would scan a handful of people a week. And our growth really at that point was just kind of a slow word of mouth growth. But the real upside there is our founding radiologist would meet with every patient personally and read the report, read their images, put the report together and go through it with each individual. This was a big benefit because it allowed us to really get that live feedback on what people are looking for. And it allowed us also to just iterate our protocols over many iterations, improving at a strong rate. Over the last 3 years, we've expanded quite a bit. And it's great to get the reception in the market that this is what people are looking for. We're at the point now we're scanning over thousands of patients every month. So with that, we have the largest data set in the world of whole body imaging based on proactive screening. We've seen the most patients and we collect the most data points per patient. And a big part of our focus for growth over the last couple of years, and certainly even more so in the future, is working with providers such as yourselves to help drive this change in a proactive manner. If I click forward, you'll see here, this is an image of one of our clinics. And I say one key strength of ours is our complete vertical integration. So we own our clinics, we only conduct whole body imaging in these facilities, and every person you deal with, from support to our front desk staff, to the technologists, to the radiologists, are Prenuvo employees. And I think this is really important to mention because it wasn't necessarily the easiest path. We could have made expansion a lot faster and easier perhaps if we were to conduct our scans out of previous diagnostic imaging centers. But we know that the patient experience would have suffered. And really it opens the doors potentially for what some people might think is a conflict of interest, right? Again, we conduct proactive whole body imaging. We are not in the business of creating unnecessary workup for us to conduct from these scans. This is also an advantage because it allows us to optimize every step of the patient journey. So here's a look at our New York clinic. You can see we put a big emphasis on creating a warm, welcoming environment that really helps reduce any sense of anxiety that people might have associated with getting this deep dive look beneath their skin. Our goal is to make disease a lot less scary. And one piece of this is, of course, catching it early, much earlier than the current status quo, which makes for a much smaller problem to deal with. And another key piece in doing that is really making the entire experience more concierge, more relaxing, just like you do for your patients. This is our, like I mentioned, this is a New York clinic. I could have pulled up any one of our 17 clinics and it would look and feel the same. Our magnets are built to give a very comfortable and relaxing feel as well. The tables have memory foam mattresses. Patients can watch TV, Netflix, listen to podcasts. There's actually, you can't see, we should probably get a new picture, but there's a screen behind an MRI safe wall where patients can see through a mirror in the field of vision. So it almost looks like they're engulfed in the actual show they're watching. It's pretty neat. So that's a big part. They're connected with and they can speak to the technologist at any time. We image the entire body in less than an hour from head to toe. So with that, the top complaint we receive from patients usually is that they didn't get to finish whatever show they were watching. So that's enough for me. That's it for the overview. If you have any questions throughout the presentation, please go ahead and use the chat feature. I'm seeing a couple people from in there already. We got Scott from San Diego. Hello, welcome. Can't wait to open our clinic there in the next couple of months. We have Safia from New York City. Welcome. So thank you for joining. But yeah, go ahead, use that chat feature if you want to ask questions. We'll do our best to get to them throughout the presentation. Of course, you can get in touch with us after the fact if you want to dive deeper into anything. And so for today's topic, like I mentioned, we're going to be talking about screening for prostate disease and cancer using the modality of our whole body imaging. So I'm going to hand it over here to Dr. Shannon Ashley to take it away. And again, thank you all for joining. Dr. Ashley, go ahead.
Oh, hello. Thank you for the information and the welcome, Eric. Thank you for all those who are tuning in to our discussion today. Again, so I'm Dr. Shannon Ashley. I'm one of the preventive medicine physicians at Prenuvo. Traditionally, my training and background is in family medicine and preventive medicine, for which I previously practiced in more traditional patient-centered care practices for nearly the last 10 years. But yes, today our topic, we're going to spend time discussing prostate health, common problems, cancer prevention, screening, diagnosis, and specifically the use or application of whole body MRI. I'm going to dive in. So basically, as we know, in primary care or preventive medicine settings, as providers, we are inevitably going to discuss prostate disease or screen for it in nearly all of our cis male patients. This is because men who live into adulthood will develop some form of prostatic problem. So the main three problems I'm going to kind of touch on today are going to be your prostatitis, benign prostatic hyperplasia, and prostate cancer. So the prostate, as we know, plays a key role in male reproduction. So I'm going to kind of just review some of the anatomy. The testicles produce the sperm, but the prostate, the seminal vesicles, they produce the semen, which is the viscous fluid in which the sperm travel. If we remember, the prostate actually consists of two lobes, the left and the right side, and where they come together, it surrounds the urethra. The base is the wider portion of the prostate gland, and that actually sits up higher in the male, so it abuts sort of the bladder area, whereas the apex, which is more narrow, sits closer to the male's rectum. And remembering that the prostate gland is an exocrine gland. Given that the male reproductive system combines sperm produced in the testicles, basically I was going to say that the two systems have two different dualities. They're one's for reproduction, and the other is going to be for elimination. And so we can imagine sort of a lot of different areas that can go wrong there. The terms that I was trying to go through are important basically in discussion about prostate cancer, since the area of the prostate cancer appears can affect the symptoms, the treatment options, and the outcomes. So this slide is to discuss the general presentation of males who come in with prostate conditions like prostatitis or benign peripheral hyperplasia or BPH. Their symptoms can range from mild or more subtle symptoms with a wider differential when they come in. So that can be someone that's got the leg weakness, back pains, and then they can have more specific or severe concerns like pelvic floor discomfort or pain. And then the more obvious, pain with urination, increased need to urinate, a slower stream or lower power of their stream, blood detected in the urine or the semen, and again, the severe back or pelvic pains. Generally, it's more common that prostate cancer alone would present with some of these lower urinary tract symptoms, or LUTs as we call them, so the hematuria or the hematospermia. But these are the symptoms that are more common in non-malignant conditions. In particular, LUTs such as the frequency, urgency, nocturia, and hesitancy, these are often related to the benign etiologies like benign prostate hyperplasia. But our patients in general, when they come in, they're going to be concerned based on these either anatomic or infectious, irritating kind of symptoms that they have, and they're going to, want us to make sure we're ruling out or screening for potential prostate cancers. So if we're going to talk on prostatitis, for many men, this can be their first brush with pelvic floor discomfort or having symptoms that are associated with the prostate gland. In general, 9 to 16% of men will develop prostatitis, which is the inflammation of the prostate, at some point in their lives. And overall, each year, prostatitis leads to almost nearly 2 million doctor visits in the US. So prostatitis, whether acute or chronic, that can present as diffuse or focal. Often we are going to first want to rule out whether or not there could be, the infectious cause could be STI. So, sexually active men may have sexually transmitted urogenital infections like urethritis, and epididymitis, which also involves the prostate, in which case then we're thinking Neisseria gonorrhea or chlamydia. But the most common pathogen in acute bacterial inflammation is actually E. coli. So the prostate infections that aren't generally from STI, those could be from like urogenital instrumentation. So that could mean like your chronic indwelling catheters, intermittent bladder catheterization, and even after a prostate biopsy. We've also studied and seen that men that suffer from depression, anxiety, and stress, they may struggle more with prostatitis symptoms, and men with other chronic pain conditions may be more susceptible. And that all generally has to do with the idea that they've probably got increased inflammation. Then when we move to a chronic prostatitis, that's normally going to be the result of back-to-back like acute prostatitis or an untreated bacterial prostatitis or someone whose treatment wasn't long enough. We know that prostatitis generally tends to affect both the peripheral and the transition zones, which we'll kind of go back and look at that picture again soon. But one important thing about prostatitis is that it's one of the most common prostate cancer mimics, and it may be impossible, or it can be very difficult, I should say, to reliably distinguish it from prostate cancer on MRI alone, which makes prostate inflammation a major source and potential for false positive results on MRI. And so when we talk about benign prostatic hyperplasia, this is going to be proliferation or sort of the increased growth of the prostatic cells. And so this can be in the glandular epithelial tissue, smooth muscle, connective tissue. But in general, when we're talking about the hyperplasia, then that alone can start to make the prostate enlarge. So not everyone that has benign prostatic hyperplasia actually gets to the point of it being enlargement, but this enlargement can then in turn lead to benign prostatic obstruction, which is where you're going to start seeing symptoms, and bladder outlet obstruction. So both the last two, when you have enlargement or obstruction, those are where you start having the symptoms that I mentioned above of the lower urinary tract system. The prevalence, benign prostatic hyperplasia increases with age, and that's what the graph to the right here is showing us. Basically, what I tell my patients is that at age 50% of males are going to have signs of benign prostatic hyperplasia. And then every 10 years after that, another 10% of men will as well. So at 60% of men, 70, and so on. BPH is not a risk factor for prostate cancer. BPH occurs primarily in the central and the transitional zones of the prostate, whereas the prostate cancer originates primarily in the peripheral part of the gland. So we're going to spend the rest of the time kind of just discussing on the prostate cancer. So prostate cancer is among one of the most common cancers in males worldwide. In the United States, it's the second leading cause of death in cancers, and that's second to lung disease. But it's also the second most commonly diagnosed cancer in males in the US, and that's secondary to skin cancer. So 1 in 8 males will be diagnosed with prostate cancer in their lifetime. 60% of cases are diagnosed in men that are over the age of 65. When we do screen appropriately and we find things early, then if we find the cancer that's still localized or regional, then there's a near 5-year survival rate of 100%. The 3.1 million there is to show that in 2024 right now, that's how many men are currently living with prostate cancer, and that a person that has a family history, they're almost double their risk. So prostate cancer, the slide above kind of reviews some of the other stats. Like I said, in 2024, there's just under 300,000 new cases currently this last year, and about 35,000 deaths of prostate cancer have occurred. One of the challenges, and a big part of what the topic today is going to be, is that we really want to be able to identify the most aggressive forms at an early stage. And so since African Americans are at greater risk in general for prostate cancer, but even more specifically for aggressive forms, this is why early detection and screening can be very important and life-saving. Real quick, the most common type of prostate cancer is prostatic adenocarcinoma, and that accounts for nearly 95% of all prostate cancers. Other types are small cell carcinoma, neuroendocrine tumors, the transitional cell carcinomas, and some sarcomas. And then again, with the average long-term prognosis for prostate cancer is actually good, despite how high of a prevalence there is. And so most cases diagnosed at an early or acute phase have a good survival rate. So talking about risk factors, the colorful image here, we have to think of what's going to be modifiable and those that are non-modifiable. So things outside of a male's control, again, with the prevalence going up with age, is going to be advanced age, one's ethnicity, as we kind of discussed with Blacks or African Americans having a higher rate of incidence, genetic factors, and with that, Ashkenazi Jewish individuals, they tend to have a higher chance of having the early mutation in the genes of the BRCA1 and 2, which can be genetic risk factors for that, and then Lynch syndrome, which is the hereditary non-polyposis colorectal cancer genes. And then family history, the small graph above, that kind of shows the difference. And with you have just one first degree relative that was diagnosed with cancer before the age of 65. So if we look there, if a 50-year-old male has one or more relatives in that category, then their relative risk of developing a prostate cancer is at 7. But a 50-year-old with no family history, their relative risk is 2. And then with the modifiable ones, that's going to fall under the category of lifestyle and diet or else environmental. So it's your modifiable risk factor can be if you're dealing with any kind of obesity, if you're not, physically active or moving a lot, kind of the dietary choices that you choose. And then if someone has occupational exposure to something, there's been studies with Agent Orange and such that can lead to increased risk of prostate cancer as well. The other side to this is are there some things that men can do to prevent it? Sort of falls hand in hand with that. So you want to be a non-smoker, continue to maintain regular physical activity, meaning also keep a healthy weight, eating your fruits and vegetables, making good choices about your fat, and then getting your proper medical screening tests. Okay, so briefly again, when we talk about just the physiology, and I wanted to bring back this image here where we could see the different zones of the prostate gland itself. The clinical manifestations of prostate cancer are frequently absent at the time of diagnosis. But the 4 zones are going to be your peripheral zone, the transition zone, central zone, and then there's a fibromuscular stroma. Around 70 to 75% of prostate cancers are located in that peripheral zone, 20 to 30 in the transitional, and a very small percentage, about 2.5 to 7 in the central zones. And then in the SEER staging, like I've alluded to before, if we do find a cancer that's still localized or regional, the 5-year survival rate is nearly 100. And the off chance that it's gotten metastasized or it's more aggressive, that does significantly drop that 5-year survival rate down to 30.6. But the combination in general still keeps the 5-year survival rate at around just 98%. So when we think about the appropriateness and the screening guidelines, this has been kind of one of the challenging topics. In 2018, the United States Preventative Task Force, which is a chart we're all familiar with, they updated their recommendations, which I think had been done in 2008, where they changed their statement for prostate screening from a D, which means it's not recommended, to a C ranking. So that's saying that they are saying to selectively offer periodic PSA test-based screenings on our professional judgment and the patient's preferences. So in men, and that was specifically in men aged 55 to 69. The updated recommendation is to apply to the general population as well as those at increased risk due to race, ethnicity, or family history. So for individuals aged 55 to 69, the decision to undergo this screening should be discussed, and basically the potential benefits and harms of screening should also be discussed with the clinician to consider whether or not this is aligned with their values and preferences. But PSA-based screening for prostate cancer is not recommended in individuals 70 and older. Again, the biggest point here is that, care really just needs to be taken to consider the patient's personal preferences, their overall health, their family history, and whatever other comorbidities they may have. Patients should be fully informed of the risks and benefits of the prostate screening, and PSA should be performed only after a comprehensive discussion of the risks and benefits for prostate cancer have been discussed. Other societies like the American Urology Association and the National Comprehensive Cancer Network They support the following in regard to PSA screening, which has some variation from what the United States Preventive Task Force says. So they would like a single base PSA level for men aged 40 to 45. Annual testing they think is reasonable for higher risk men starting at age 45. And they kind of add that important change that we look for. If there's a change of 0.75 nanograms in a year, then they consider that to be suspicious. They also support the use of 2 separate PSAs before we confirm a true increase in a PSA level. And then they also would suggest that if a man's life expectancy is 10 years or less, or they have significant comorbidities, then screening may be discontinued at that time. So screening at this time, it's just not clear if the benefits of prostate screening outweigh the risk for most men. After discussing pros and cons of screening, though, with doctors, some men may reasonably choose to go ahead and still get screened. And when they do, that's when we are generally going to start discussing the PSA. And so PSA is produced in the prostate. It's there to help with the process of fertilization. It's primarily produced in the epithelial cells that are lining the ducts of the prostate gland. Generally speaking, most PSAs should be in semen. It's not actually designed for blood and really shouldn't exist, but yet we do the PSA serum blood test, which really is actually evaluating for the PSA that's leaked from the epithelial cells into the bloodstream. So again, most proteins, as you remember, they're released not fully developed, and they still need to get snipped and into their mature forms. So when PSA is put into its effectively active form, that's just before it penetrates the capillary membranes and enters the systemic circulation. A small portion of the active PSA undergoes proteolysis and becomes inactive, which becomes that free PSA. And so when it enters the bloodstream, it remains unbound. Basically, this description is important when we're discussing like the screening potential of serum PSA levels. And active PSA that reaches the bloodstream rapidly becomes bound to circulating protease inhibitors. So basically, there's no specific normal or abnormal level for PSA in the blood. In the past, levels that are 4 and under were considered normal. But there are some individuals that have PSA of 4 and under and they still have prostate cancer. And then there's many that have higher PSA levels that are about 4 to 10 and they don't have prostate cancer. So in addition, there's various factors that can sort of change a person's PSA levels and make them fluctuate. So what I was just alluding to, some of the variable examples we've already been discussing are that the PSA levels can increase, with age, the prostate gland size, and inflammation or infection. A person that has a recent prostate biopsy will also increase their PSA level, as can ejaculation or vigorous exercise, like someone who's bicycling, even within 2 days before the testing. Certain medications, and this is an important topic here, is that, certain medications like taking testosterone or other medications that can rise the testosterone levels, that will rise that can put a rise in the PSA. But conversely, the drugs like finasteride or dutasteride, which are used in treating BPH, that can lower the PSA. To me, this is a pretty big topic that we need to consider in primary care, but we won't go into great detail here today for that. So the serum PSA is a superior test to the digital rectal exam and to transrectal prostate ultrasonography for detecting early prostate cancer. So when using a PSA value greater than 4, detection rates for prostate cancer achieve a specificity of 91%. In contrast, the digital rectal exam, which has fallen out of favor, is far less specific at only 59%. Initially, the urologic and medical community, they heartily embraced the potential of PSA screenings to detect early prostate cancer, and that was with the intent to avoid any disease progression and decrease mortality. However, an increased use of PSA testing, many individuals experienced adverse effects and unnecessary procedures because their PSA values were elevated secondary to benign conditions. So the risk of overdiagnosis, particularly overtreatment, can be minimized by carefully reviewing and discussing the variable options, the benefits and risks of each stage in the diagnostic process. So while the PSA blood test is a very powerful tool, due to its potential for overdiagnosis and treatment, it's often criticized. The issue, may be arising from this overlap that we kind of see with the test. Basically, it's it's not prostate cancer specific, but it's prostate specific. And so the specificity of this tool depends on how much prostate tissue a male has. It's more sensitive in younger men because they have a more limited amount of that transitional zone tissue, and the bulk of their prostate tends to be in the peripheral zone. And so one thing that's important to note is that prostate cancer cells actually do not produce more PSA than benign cells. In fact, they tend to manufacture less. So this bottom image here is kind of show what I'm discussing. But malignant cells just more easily allow PSA to pass through their cell wall into the surrounding extracellular fluid and eventually reach the bloodstream. The process occurs because the malignant cells, they lack that basal layer, and otherwise that would restrict typically the passage of PSA outside the cell. One way to make the PSA value more impactful is to see how much there is and how much of that is free. So this kind of gets into the adjunct PSA testing, which is used when our baseline PSA is considered to be equivocal in some. That's after we've first repeated them. So this kind of is how we start talking about the free and bound PSA. We know that prostate cancer is associated with a lower percentage of the free PSA in the serum as compared with benign conditions. So basically, if someone has high amounts of free PSA, like 30%, then they can have a good reassurance that most of the PSA in the blood that they're detecting is from benign cells. However, when the PSA in one's blood test is more bound, that leaves limited amounts of free, then that's a stronger marker that there's something going on like a cancer. There's some other byproducts, other types of free PSA and sibling molecules to PSA that are like the human calcrein markers. And these are part of more advanced PSA testing that you may see urologists do that are part of like 4K scores or the Prostatic Health Index tool. Those are mathematical equations to predict the probability of how aggressive a cancer would be, but they're very expensive tests. And so due to the high cost and possibly lack of availability, a lot of urologists will consider getting a PSA density. So the PSA density is determined by comparing the PSA values that we got with the prostate size. And that's measured typically by transrectal ultrasound or by the prostatic magnetic resonance imaging, so MRI. The use of these adjunct laboratory tests to inform the decision to biopsy varies among a lot of experts, including among the leaders in the research on this topic. So with some specialists using MRI more frequently than others. And so I'm briefly going to conclude my portion just to give a refresher on how they report the pathology findings from prostate biopsies. In approximately 93 of prostate cancer cases diagnosed in the United States, the disease is localized and classified according to the risk of the progression or death on the basis of tumor grade, tumor stage, and PSA level. Tumor grade has traditionally been categorized by the Gleason score, and on the left I kind of review what Gleason score is made of, but it's now reported in terms of group grade. So with ranges of group grade stage 1 being equivalent to what a combined Gleason score of 6 would have been, and a group grade of 5 being more equivalent to Gleason scores 9 or 10. So this new severity rating system is considered more intuitive to patients. All right. And with that, we're gonna continue the conversation, but now to take you kind of further into the use of whole body MRI and screening for prostate cancer, I'd like to introduce Dr. Muasher, and he is a board certified interventional and diagnostic radiologist. Prior to joining Prenuvo, he established targeted prostate programs between Los Angeles and San Francisco at 2 different regional health systems. He's personally performed over 500 prostate biopsies, and currently he runs prostatic imaging clinic focused on both the screening for prostate cancer and active surveillance for known cancers. So welcome, Dr. Muasher.
Thank you. All right. Okay. So, we've already covered this to a certain degree, but I just thought, we could kind of review it one more time before we get more into how imaging helps us diagnosing prostate disease. Prostate disease really is a paradox. On one hand, prostate cancer is extremely common, and death from prostate cancer is extremely common. So if an older man wants to, if he wants to think about, I want to be screened for cancer, I want to make sure I don't die of cancer. Actually, one of the most likely causes of death from cancer in older men is prostate cancer. So in that sense, prostate cancer is underdiagnosed, and a lot of men are being diagnosed after they already develop metastatic disease. On the other hand, an equally compelling argument can be made that prostate cancer is overdiagnosed, and that kind of ties into the conflicting recommendations for screening the findings of the task force. One of the reasons that prostate cancer is often thought of as being overdiagnosed is that because PSA is not a reliable test in and of itself, like as a sole screening modality, and the same thing goes with digital rectal exam. The traditional model has been to biopsy men who have an elevated PSA, and as a result, we get a lot of diagnoses of Gleason 6 or Gleason 3 plus 4 equals 7 cancers. There's a lot of debate over whether Gleason 6 cancer should even be called cancer or whether the diagnosis of cancer should really start with Gleason 7. And the problem with this is that Gleason 6 is by far the most common type of prostate cancer which is diagnosed. And it's a disease that is likely non-lethal. And so you have, hundreds of thousands of men across the country and worldwide who are diagnosed with low-grade prostate cancers like Gleason 6 or in some cases Gleason 3 plus 4 equals 7 cancers. They probably don't need treatment, but many of them will end up pursuing radiation therapy, surgery, or other therapies, which, both have a cost and they have a morbidity associated with them in terms of side effects. And so we can see that, these are different screening guidelines from different organizations. Each healthcare system is going to have its own point of view, and all of these guidelines are evolving. And a big reason for that, there are a couple of reasons for that. One is greater understanding of what Gleason 6 and favorable Gleason 7 cancers represent in terms of true danger to the patient, and also the increasing role of imaging in the workup and diagnosis of prostate cancer. So how can imaging help us? So what we can do is, the way I look at it is, if a man is getting a PSA drawn and the PSA is low, let's say below 1, the chance that they have a clinically significant prostate cancer is extremely low. But if the PSA is high, or if it's in that kind of intermediate zone, we don't know that they have prostate cancer, but at least it kind of raises an alarm bell that they could have prostate cancer. And now we have to figure out, well, how do we differentiate men with high PSA? Like, do we biopsy everybody? Do we watch everybody? What is our approach going to be if a man chooses to undergo PSA screening and has a high PSA, or even if they don't undergo PSA screening, but they have another reason to suspect that they may have prostate cancer. And so the system we have in MRI is called the PIRAD system. So an MRI is done, and we'll talk about two different types of MRIs today. One is a whole body MRI that we offer at Prenuvo, and then one is the dedicated prostate MRI that includes IV gadolinium. So when we do an MRI, we can learn a lot of things about the gland. But one of the primary things we're looking for are suspicious lesions. And we tend to characterize these lesions according to this PIRAD system, which is sort of developed after the BI-RAD system that we use in breast, and it's meant to mimic it to a certain degree. Essentially, a PIRAD's 1 or 2, if you see that on a report, it means that this report is essentially negative. It's impossible to ever say, even with a quote-unquote normal MRI, that someone doesn't have prostate cancer, because prostate cancer is so common, and particularly low-grade or infiltrative cancers may have no imaging correlates at all. But what we say with PIRADS 1 or 2 is essentially a negative study. They have very low chance of cancer. Once we get into PIRADS 4 and 5, now we're starting to talk about patients that we believe have a greater than, let's say, 50% chance of cancer. And PIRADS 3 is in the more intermediate category, and the literature is varied on what this represents, and it probably changes depending on, the institution, the experience of the radiologist reading it. But you typically think of PIRADS 3 lesions as maybe having anywhere from like a 10 to 30% chance of clinically significant cancer. And again, I want to highlight that word clinically significant that is in all of these categories, because in many ways, the detriment of screening for prostate cancer has been these low-grade, low-volume Gleason 6 cancers, which we currently classify as cancers, but we would say that they're not clinically significant cancers. We're not trying to find low-volume, low-grade Gleason 6 cancers. We're trying to find cancers that are at high risk of growing and metastasizing. One article that I think is really instructive to give a global view of prostate cancer and exactly what we're dealing with is this article that came out in the New England Journal about 18 months ago. This is a study out in England that's it went through 15-year outcomes for patients with prostate cancer. The patients were put into active surveillance groups, surgery groups, and radiation groups. And the interesting thing is that the patients were divided into groups regardless of how aggressive their prostate cancer was. So there were men with low-grade cancers who had surgery. There were men with high-grade cancers who had monitoring. And very interestingly, keep going, after 15 years of follow-up, there was almost no difference in prostate cancer mortality in all of the groups. And overall prostate cancer-specific mortality was low, regardless of which group they were in. So this is why you have organizations that shy away from screening once men are past a certain age. Because if the life expectancy, not just at 5 years, but at 15 years is high following a diagnosis of prostate cancer, while it may be important to screen someone who's 55 or 60, there's a big debate over whether screening someone who's 75 or 80 is appropriate, given how long men tend to live following a diagnosis of prostate cancer. So let me talk a little bit about exactly what we do at Prenuvo and how we can be involved in screening. So typically patients who come to get whole body MRI scans, some of them may have specific concerns or even prostate specific concerns, but the majority of them are looking for general proactive screening for all types of cancers and health conditions. And yet, prostate disease is one of the most common things that we diagnose because all men are at risk for it, and BPH, prostatitis, and prostate cancer are such common diagnoses. And so what we do that differs from a dedicated prostate MRI essentially is that we don't use IV contrast in our studies. And really in the general population, what we do is as good as a prostate MRI with contrast. Now, if we see an abnormality, which, that's, relatively uncommon, compared to the number of men who get whole body MRIs, then we will often recommend the contrast enhanced prostate MRI. But contrast is only useful if you see an abnormality on the non-contrast images. So if your non-contrast images, which is what we obtained, if your non-contrast images of the prostate gland are normal, you don't need the contrast, actually. And many patients would prefer to avoid getting an IV and getting an infusion of a medication, regardless of how benign that medication is. So what we're doing in terms of, the image quality, the quality of our diffusion restriction, small field of view, is in every way the equal and oftentimes superior to contrast-enhanced prostate MRIs that are done out in the community. And again, this allows us to have earlier and more accurate detection of clinically significant prostate cancers. One of the most important things we do, actually, is we give an accurate measurement of prostate size. This is so important because this now allows you to actually use your PSA usefully rather than seeing it in isolation. Digital rectal exam is notoriously bad at estimating prostate size, even with experienced practitioners. With every Prenuvo study, we provide, regardless of whether there's prostate concerns or BPH, we provide a volumetric measurement of the prostate size. So patients will know, I have a 20-gram gland, I have a 50-gram gland, I have an 80-gram gland, regardless of whether or not they've ever had symptoms, ever seen a urologist, ever had a PSA drawn. They now know how large their prostate gland is, which can give them an idea if they have prostate symptoms in the future, in terms of lower urinary tract symptoms. It can also give you as the physician a guide when interpreting their PSA. And then one of the most powerful things about the Prenuvo model is that, a lot of our patients, they come in, they have a certain set of diagnoses from their whole body MRI, and then we typically recommend some interval for follow-up. So, our typical patients will come back either annually or every 2 years for a repeat whole body MRI. And in that way, you can follow these issues over time. So if a man has BPH, you can see how quickly that BPH is progressing, or maybe it's progressing slowly, maybe it's progressing quickly. Similarly, if they have a mildly suspicious abnormality, maybe something that's not definitely a cancer, you can keep an eye on it, and you don't necessarily have to rush to biopsy, rush to something else. Particularly if their PSA is normal, a suspicious abnormality on MRI may only need to be followed with imaging rather than aggressively worked up. The other thing is that we can also see associated abnormalities. So in addition to BPH, we get a good look at the bladder. We can see bladder wall thickening, diverticular stones, and some of the associated findings from BPH. All right, so now we're going to do some cases, and I've kind of picked each case to illustrate a different, kind of clinical scenario. These are all Prenuvo cases. These are all real cases. All right, we'll go through this one. Okay, so this is a good one. So this is sort of our ideal case. This is a 61-year-old male, so he's in the perfect screening age by most recommendations. He has a PSA of 3.7, which, a lot of people would say, well, that's less than 4, so that's a normal PSA. However, he has a normal prostate gland volume. He doesn't have any BPH. His prostate gland volume is only 25 ml or 25 grams. So actually his PSA is quite high for how small his gland is. And then here we go that, I don't know if you can perceive on the left, but where the circle is, he actually has a fairly large cancer towards the apex of his gland with evidence for possibly early extracapsular extension. So this is exactly the kind of patient we are trying to find and diagnose. Someone who either, their PSA is non-contributory or maybe their PSA is upper limits of normal, but they have a significant cancer. All right, we can go to case number 2. This is sort of the opposite now of that other case. So this was a 67-year-old male. PSA was elevated relative to his gland size. No lesion was found. However, and this is a case from a year or two ago, his PSA continued to rise. He ended up getting a template biopsy of his prostate gland, and he did have biopsy-proven intermediate grade cancer. And this is just to make the point that our data points, they really need to be concordant for us to exclude prostate cancer or exclude clinically significant prostate cancer. If a patient has a quote-unquote normal MRI, it doesn't mean they don't have prostate cancer. It just means they're at lower risk for it. And if their PSA continues to rise, they should still be getting worked up, all right? So while MRI can do a lot, it's not perfect, and not every negative MRI means someone doesn't have prostate cancer. This is, I will say, not the most common scenario, but it exists, and we should be aware of it. All right, we'll go to the next case. All right, here's a 58-year-old male, no PSA, no concerns about prostate cancer. And you can see that black dot with that almost imperceptible blue arrow pointing to it in the left peripheral zone, measuring less than a centimeter. That is a PIRADS 4 lesion. It has not been biopsied yet. This is a relatively new case. I can almost guarantee, based on its imaging characteristics, it's going to represent at least Gleason 7 cancer or higher. And in this case, we've caught this cancer far in advance of, it's not near the urethra, it's not near the periphery of the gland. So with radiation or surgery, this is small organ confined disease, and you know that this cancer is never going to become an issue in the future. This is actually a case that we saw recently that is more of where the indication was more the type of indication you would see for a traditional prostate MRI. 82-year-old male, he had an elevated PSA, he had a relatively small prostate gland, and he had already been worked up for prostate cancer, had been biopsied, and was told that he didn't have prostate cancer. Now he comes in for MRI, and sure enough, he has actually quite a large tumor in the anterior gland where those arrows are. And you can see that, the rectum is that structure that is on our image below the prostate gland. So when transrectal biopsies are performed, they typically sample the posterior gland. So it's very easy, unless you know where to go, to miss a large lesion in the anterior gland, which is what this gentleman has. So this is bulky disease, and he would be at risk for metastatic disease if left unchecked. This is a very common scenario. So this is a 66-year-old male, elevated PSA of 12. So PSA seems like it's off the charts. And historically, someone with a PSA of this level, they would get worked up and they would probably have a prostate biopsy. In this case, however, we see that he has significant BPH with a gland that's greater than 100 grams or 100 milliliters. So actually his PSA is normal for his gland size, and we don't see a lesion. So we know that this patient is at low risk for prostate cancer, and we also know that he can safely defer having any prostate biopsy, and we can just trend his PSA going forward. And of course, now he also knows he has a diagnosis of BPH and can seek appropriate treatment for that. So those are my 5 cases, and we tried to keep this presentation kind of under time, and I think we're doing okay from that perspective. I'm going to check the chat here. So if anyone has any questions, feel free to enter them on the chat, and I can take them, or others can take them.
Awesome. Thank you, Dr. Ashley and Dr. Muasher. Really appreciate the insightful walkthroughs today. As Dr. Muasher mentioned, we have some time, and I can see most of you are still hanging around. Feel free, if you have any questions specific to the presentation or just around Prenuvo in general, you can drop them in, and while we have a few minutes here, we'd be happy to take those. You can also reach us at practitioners@prenuvo.com after the fact if you want to learn more or ask other questions. It looks like we do.
So this is a question about PSA prior to a scan. That's a great question. It helps us, let me put it that way, when we have a PSA, interpreting the MRI. However, if someone doesn't want to get a PSA because they know that there's a lot of controversy in terms of using that, I don't think they need to have one. In other words, if they don't get a PSA and their prostate MRI looks essentially normal, they're probably at low risk, although not no risk for prostate cancer, and they can decide whether they want to screen more aggressively. However, if they get an MRI and the prostate gland looks abnormal, they must have a PSA, I would say. So that's the way I think about PSA. I don't think it's a requirement. I would say that patients in general who are interested in whole body MRI screening may want to be more aggressive about prostate cancer screening. And I don't know if Dr. Ashley wanted to add to that, or...
I just think from the standpoint of, our ability to also, when we're giving feedback after you do your Prenuvo scan, having some lab work can also just be beneficial for your overall experience, but it's so recommended. It'd be encouraged, but I agree with Dr. Muasher on the fact that it's not necessary.
Dr. Muasher, we have a question here from Melvin. Why is Prenuvo not using contrast?
Yeah, so contrast, I guess you could think of this question as 2 ways. Why don't we use contrast in any part of the scan, or why don't we use this specifically in prostate? For prostate, I would say we use our scan as a screening study, whereas contrast is typically used in the prostate MRI more for problem solving and further characterization of a known abnormality. So the Prenuvo model is for screening specifically. I think also not starting an IV and giving a medication lowers the barrier to entry, quite frankly, for patients to get screened. And it allows us to truly say that this is that there's no, I don't know the way I would put it, there's sort of no harm done to come in and get a whole body MRI. Nothing is going to touch you, nothing is going to invade your body, And that even goes beyond concerns with gadolinium, which I don't share, but many patients have.
Thank you. Anything to add to that one, Dr. Ashley?
I agree.
Thank you. Okay, do we have any other questions from the attendees, the audience here? A follow-up question from Melvin. If we request for contrast, we refer to another facility? Question mark. Yes, that would be if I'm sure I can jump in there. Prenuvo, we don't administer contrast with our screening exams.
This is like a very specific question we had over finasteride. Yeah, so finasteride typically drops the PSA by 50%. Should I get a biopsy? So I would argue that if you have PSA concerns, you should get an MRI actually, rather than jumping to biopsy. I think that's sort of one of the take-home points of the presentation be, is that we really want to select the people who get biopsies, and we want to limit the number of biopsies that are done, as a medical society, you know what I mean? So I would say imaging is probably the next step, and that could be whole body if you have other concerns, or it could be dedicated prostate MRIs at another facility.
Okay, I'm not seeing more questions come through. We're running up to the hour here. So I'll close it out. I appreciate everyone hopping in today for the live session, and for those of you that will watch the recorded version down the line. We do these webinars once a month, and so I'm big thankful to our physicians on staff that make time to run through these webinars. Every month we focus on a specific topic, and we've done several different topics in the past, so you can find all these videos on our YouTube channel. You can also reach out to us to look for more, to have us send you the links. The big focus today was on prostate cancer, and cancer tends to be a big focus, or a big thing that people associate with us. And to reiterate, right, we are a whole body imaging facility. We look at a whole lot beyond just cancer, everything from MSK and metabolic and chronic conditions, which I think many of our providers who sort of look at us as a core component in what is essentially an annual physical really get the benefits across the board. So if you want to learn more about the prostate or any of the other areas that we image, and shoot us an email, give us a call. You can reach us at practitioners@prenuvo.com. I think I dropped my email in the chat a little bit earlier. You can feel free to reach out to me directly, and we can continue the conversation. But I want to thank Dr. Ashley and Dr. Muasher for making the time today. I learned a lot still. I'm learning a lot every day working here, listening to the fine folks like you. So I appreciate your time today, and I appreciate everyone who hopped on. Okay? Stay tuned and look for an update for the next webinar. Take care, everybody.